We're going to talk about this problem, shoulder dislocations, an algorithm to treat it, the solution for my individual patient, and how to make it easier. Our problem today is a 26-year-old woman who is an ultimate Frisbee athlete. I'm not sure if you've ever seen this sport, but it's pretty intense. This is how she initially dislocated, and she's dislocated subsequently. She has continued apprehension, but otherwise full range of motion. And unfortunately, she actually has a higher Baton score than I do, so she has that to deal with as well. And then she has a Hill-Sachs lesion. We know from Sugaya that multiple dislocations or recurrent dislocations leads to glenoid changes in about 90% of patients. Additionally, 40 of 100 glenoids show attritional bone loss. This patient of mine has very small remodeling at the anterior inferior glenoid, and she has a low distance to dislocate. We are all very well versed in the on-track, off-track discussion given by Yamamoto as well as Bankart. But Lynn's group talks about this distance to dislocate matters even in an on-track lesion. And what I have here is the graph from their chart showing that changes from 0 to 8 millimeters of distance to dislocate actually can increase the risk of dislocation 38.5%. So we need to look at this. And when you look, can you make this, go back. Can you turn on the videos on these two? The two options here, if you look on your right-hand side, this is a larger Hill-Sachs lesion. Let's see if that works. There we go. And the first one shows a larger Hill-Sachs lesion. This one's our patient. Both are 3 millimeters distance to dislocate. The problem in my patient's situation is that she's a much smaller glenoid.